Regarding the radial head is providing a valgus stability, especially in MCL deficient elbows. It gives longitudinal stability and aid the interosseous membrane. It's a load transfer, and 60% of the load is transferred at elbow. Where at radial head excision, load is transferred through the allohumeral joint, increases the risk of osteoarthritis. Classification is Mason classification of radial head. Type 1 is undisplaced, type 2 is displaced, type 3 is comminuted, type 4 is straight with dislocation. Radial neck fractures, undisplaced. Radial neck fractures classified by Jupiter classification. Type 1 is undisplaced, type 2 is less than 30%, type 3 is 30 to 6 degree, and type 4 is 6 to 9 degree. Chen et al. Low recommendation, but if more than 3 parts, arthroplasty is advisable. Essex low pressure fracture, radial head fracture through the interosseous membrane, disrupted, extending to the distal radioulnar joint, indicates with forearm pain. Examine ridge in every distal radial head fracture. Unstable relationship with the radius ulna leads to proximal migration of radius. This results in secondary distal radioulnar joint pathology, ulnar carpal abutment. For a radial head, it's a Greenspan view, radiocapitellar view, oblique lateral view of arm in supination and beam directed 45 degrees. Treatment: treat the pathology, radial head or shaft fracture, pin the distal radioulnar joint. It's in for 6 weeks in neutral to facilitate ligamentous healing. In the interosseous membrane, if there is a disruption, there has been advice about central band of interosseous membrane reconstruction. If there is a need to plan to reduce, aspirate the hematoma, inject local anesthesia, and which will help facilitate reduction. Regarding the closer reduction, Patterson technique: if neck angulated more than 30 degree or displaced more than 4 millimeter, reduce range of motion. Then what you do is do a traction, varus pronate, while elbow flex in 9 degrees, and direct pressure on the radial head. The KY technique, joystick technique, is possible. That is Metazu technique. Retrograde nail is passed across the fracture site and reduced by rotating it. A superficial radial nerve injury is a risk. 2 mm plates can be used with minimal loss even when placed on the radial neck. The best location: mark the radial styloid, mark the distal tubercle. The space between it is the area where you can place the plate. Safe zone implantation appears yellow and thinner articular surface. It's about 90 degree arc between radial styloid and distal tubercle. Indication is more than 3 fragments and non-constructible radial head fractures, but beware of radial migration. Contraindication for excisions: unstable elbow joint, injury to the interosseous membrane. Unstable L joint mean coronoid fracture and lateral collateral ligament. Radial head replacements can be Vitalium. Vitalium prosthesis cause aseptic loosening. Silicone prosthesis risk of synovitis. Overstuffing joint leads to loss of extension. Think of it as a spacer. The Dunberg showed to prevent overstuffing, the radial head replacement should be 1 centimeter proximal to the lateral edge of the coronoid articular surface. So to prevent overstuffing, place radial head 1 millimeter proximal to the lateral edge of the coronoid articular surface. Fracture excision, if smaller than 25% involved, may result in proximal radial migration and carpal abutment. Regarding the radial head replacement, it can be unipolar or bipolar. It can be press fit, and it can be pyrocarbon as well. Complication is with radial head excision is reduced range of motion. Loss of pronation is more than supination. Radial head overgrowth is possible, usually does not affect range of motion, osteonecrosis, and synovitis.